Welcome. In the previous session we discussed about the physiology of ocular movements, and in this session we will discuss the physiology of binocular vision, its abnormalities under various circumstances such as strabismus, and the adaptations which the visual system can undertake to prevent these abnormalities from occurring. When an area in the retina is stimulated either by light from outside or mechanically or electrically, the resulting sensation is always of light, and the subjective sensation is that the light is coming from a specific direction in the visual space, which is called the directional value of that retinal area. An area nasal to the fovea has a directional value temporal to the fixation target, and an area temporal to the fovea has a directional value nasal to the fixation target. Normal binocular vision is the process of fusing the two retinal images, one each in the retina of each eye, of a target in the visual space into a single three-dimensional visual perception. In this session we will see several of these diagrams, and we must note that there is a nodal point in the eye just anterior to the crystalline lens in the region of the pupil, light rays passing through which do not undergo any deviation. Also, we will be using the green straight line to connect the fovea and the nodal point, and in the fixating eye the target of fixation as well. Retinal correspondence is an important term to understand. When an object in the visual space stimulates paired retinal areas in the two eyes to give a sensation of a subjectively single direction in visual space without causing diplopia, the paired retinal points are called corresponding points. So corresponding retinal areas have the same directional value, and this is important to remember, that the corresponding retinal areas have the same subjective directional value. Under normal circumstances, the two fovea are corresponding to each other, and this situation is called normal retinal correspondence, or NRC. The corresponding points in the two retinas in NRC are located equidistant from the two foveas in each eye. As we see here in this diagram, points temporal to fovea in one eye correspond to points nasal to the fovea in the other eye, and the distances of these corresponding points from their respective fovea are equal. Similarly, points nasal to the fovea in one eye correspond to points temporal to the fovea in the other eye, and the distance of these corresponding points from their respective fovea are equal. In contrast, points superior to fovea in one eye correspond to points superior to the fovea in the other eye, and so does inferior retinal points. This difference is because the eyes are horizontally separated from each other but normally are not vertically separated from each other. And when an object in the visual space stimulates two retinal points in the two eyes to give a sensation of subjectively different directions in visual space, thus causing diplopia, the retinal points are called non-corresponding retinal points. In this session from here on, we will be representing corresponding retinal areas with similar subjective sense of visual direction with same shade of brown. In this diagram, we shows the situation in a patient with right eye esotropia with normal retinal correspondence. The deviated right eye having esotropia has its cornea rotated excessively nasally, and thus the fovea is rotated excessively temporally. As a result, the target of fixation fixated by the fixating left eye projects to an area in the deviated right eye nasal to its fovea. But since the retinal correspondence is normal, the subjective sense of direction of the fovea in the deviated right eye is similar to the subjective sense of direction of the fovea of the fixating left eye. So the area where the target of fixation projects in the deviated right eye, being nasal to its fovea, has a subjective sense of direction temporal to the subjective sense of direction of the fovea. As a result, the deviated right eye locates the target at a location temporal to the location where the fixating left eye locates the target, and the patient complains of diplopia or double vision. In abnormal retinal correspondence, there is subjective sensation of a single direction in the visual space without causing diplopia, but the corresponding points are not equidistant from the fovea in each eye. Or in other words, the fovea in one eye corresponds to a non-foveal retinal area in the other eye. In this diagram representing the situation in a patient with right eye esotropia but with anomalous retinal correspondence, the target of fixation projects to the fovea in the fixating left eye but to a non-foveal point in the deviated right eye. But there is a sensory adaptation in the visual cortex called anomalous retinal correspondence, because of which the retinal area in the deviated right eye receiving the image of the target of fixation comes to have the same subjective sense of direction as the fovea of the fixating eye, and thus the patient perceives a single target with both eyes open and does not complain of any diplopia. Anomalous is the more appropriate word. A horopter is a line in space, a target located on any point of which stimulates corresponding retinal points in the two eyes and thus do not cause any diplopia. Theoretically, it is a circle passing through the nodal points of the two eyes and the target of fixation and is called the Vieth-Muller circle. But when determined experimentally, it is a flatter curve called empirical horopter, and this difference between the empirical horopter and the Vieth-Muller circle is called the Herring-Hillebrand-Horopter deviation. So one of the points on the horopter is the target of fixation, which stimulates both fovea which are corresponding to each other, and any other point on the horopter such as this one also stimulates corresponding retinal points. And as we have already seen, corresponding retinal points in non-foveal locations are nasal to the fovea in one eye and temporal to the fovea in the other eye. And as we shall see later in this session, targets located in the midline but outside the horopter project to temporal retinal areas in both the eyes when they are in the midline but proximal to the target of fixation, or project to nasal retinal areas in both the eyes when they are in the midline but distal to the target of fixation. Each target of fixation with its unique orientation of the two visual axes towards it has a unique horopter, with the fixation target lying in the center of the horopter. And the horopter lines exist in both horizontal orientation, which can be described from a top view, and a vertical orientation, which can be described from a side view. Horizontal horopters become more curved as the distance of fixation target increases, and the vertical horopter for a particular fixation distance is further away in the superior visual field as compared to the inferior visual field, and this superior-inferior discrepancy of the vertical horopter increases with the increase in distance of the fixation target. By the definition of horopter, targets lying outside the horopter will cause diplopia. However, the visual system can create a perception of single image of targets lying slightly outside the horopter. This limited area in space, including the horopter and extending slightly anterior and slightly posterior to the horopter, and targets located within which are perceived without diplopia, is called Panum's area of single binocular vision. As we can see, the Panum's area is wider peripherally as compared to in the midline. When the target is located outside the Panum's area, physiologic diplopia is perceived by the subject. When the object point located outside the Panum's area is distal to the target of fixation, it will result in uncrossed physiologic diplopia. This is because that target will be stimulating retinal areas in either eye nasal to their respective fovea and thus having a sense of direction temporally. For the right eye, the image perceived by the right eye is temporal to the image perceived by the left eye, and for the left eye, the image perceived by the left eye is temporal to the image perceived by the right eye. As a result, the image seen by the right eye will be located to the right of the image seen by the left eye, and this is called uncrossed physiologic diplopia. But when the target located outside the Panum's area is proximal to the fixation target, it will cause crossed physiologic diplopia because that target will be stimulating retinal areas in either eye temporal to their respective fovea, and these retinal areas will have a subjective sense of direction nasally. For the right eye, the image perceived by the right eye is nasal to the image perceived by the left eye, and for the left eye, the image perceived by the left eye is nasal to the image perceived by the right eye. As a result, the image seen by the right eye will be to the left of the image seen by the left eye, and so this will result in crossed physiologic diplopia. Children without strabismus may perceive physiologic diplopia and complain about it. Fusion is the unification at the level of the visual cortex of the two images, one from each eye, of an object into a single perception, and the decussation of the optic nerve fibers at the optic chiasm is essential for binocular fusion. For fusion, the two images need to be similar in size and shape. For central fusion of images projecting on the fovea, fusion requires very little dissimilarity of the two images as the receptive fields are small in the fovea. Whereas for peripheral fusion of images projecting on the peripheral retina, fusion can occur with more dissimilarity of the two images as the receptive fields are larger in the retinal periphery. But when two images are very dissimilar, such as when one eye is allowed to see only red light and the other eye is allowed to see only green light, or when one eye is allowed to see a horizontal line and the other eye is allowed to see a vertical line, image is perceived from one fovea at a time, and the images seen by either eye alternates between each other at the level of consciousness, and this is known as visual rivalry. And among the three components of fusion, as we will be discussing next, motor fusion and some amount of stereopsis can occur with rival stimuli, but sensory fusion does not occur with rival stimuli. As we have mentioned, fusion has three components, and they are motor fusion, sensory fusion and stereopsis, all of which occur together simultaneously. Motor fusion refers to the vergence movements which make the two images of an object fall on corresponding retinal points in the two eyes, and motor fusion is induced by either heterophorias or artificially with prisms. Heterophoria refers to latent strabismus, which we will be discussing in the session on evaluation of a strabismus patient. Sensory fusion is based on topographic correspondence between corresponding retinal areas in the two eyes and their corresponding areas in the visual cortex, so that images of an object falling on corresponding retinal points in the two eyes are perceived as a single image at the level of consciousness. Stereopsis is the binocular perception of depth and is considered to be the highest form of binocular cooperation. Perception of depth by stereopsis can occur only when both the eyes are working in a coordinated manner. But perception of depth by other means can occur monocularly, as we will be discussing shortly. Stereopsis is induced by horizontal disparity of the images of an object projected in the two eyes, and this horizontal disparity occurs because of the horizontal separation between the two eyes and occurs with an object which is not located on the Horopter. And the horizontal disparity between these two images alone is sufficient for stereopsis. So we have to remember that stereopsis is binocular and is induced by horizontal disparity of the two images. This diagram shows the horizontal disparity between the two images projected on the two eyes by a target not lying on the Horopter, and this horizontal disparity induces stereopsis. When targets lie in the midline, binasal disparity suggests that the target lies distal to the fixation point, and when there is bitemporal disparity, it suggests that the target lies proximal to the fixation point. As we have mentioned in the discussion on physiological diplopia, a target lying distal to the fixation point will have their images separated in an uncrossed manner, and with the target proximal to the fixation point, the images will be separated in a crossed manner, and this separation of images leads to a sensation of the target being either distal to or proximal to the fixation point, thus giving a sensation of depth. Stereopsis can also occur with an object located away from the midline. although it stimulates the nasal retina in one eye and the temporal retina in the other eye. And the area from which a target can induce stereopsis is slightly larger than the Panum's area of single binocular vision. Stereoacuity is the minimum horizontal separation between the two images in the two eyes required to perceive stereopsis, and stereoacuity is finest in the fovea, requiring only 10 seconds of arc separation between the two images to perceive stereopsis. Stereoacuity decreases towards the retinal periphery, decreases as fixation distance increases with increasing interpupillary distance, and decreases with decreased visual acuity. As we have mentioned, stereopsis is not the only method of depth perception. Depth perception can also occur monocularly with cues such as relative object size, shadows and highlights, overlapping of objects, perspective and motion parallax. At the onset of strabismus, corresponding retinal areas of the two eyes do not have the same subjective sense of direction in the visual space, and this results in two phenomena. One is diplopia and the other is confusion or rivalry. Diplopia occurs in strabismus because a target in the visual space projects to two areas in the two retinas which are non-corresponding and thus have different subjective sense of direction in the visual space. In the fixating eye, the image falls on the fovea, and in the deviating eye, it falls outside the fovea. This we have discussed when we previously discussed a patient with strabismus and normal retinal correspondence. The foveal image in the fixating eye is clearer than the non-foveal image in the deviating eye, and children below 7 to 9 years of age with an immature visual system can suppress the non-foveal image and thus avoid diplopia. But adults and children older than 7 to 9 years of age with a mature visual system cannot suppress either image and thus perceive diplopia. And this is very important to remember, that children less than 7 to 9 years of age can suppress the non-foveal image, but older individuals cannot. Binocular diplopia can also occur without strabismus, in which case it is called central fusion disruption, and it occurs in individuals with a mature visual system and can occur following head trauma or treatment of unilateral amblyopia. So in central fusion disruption, diplopia is binocular, that is, diplopia disappears when either of the eyes is closed. But in central fusion disruption, strabismus does not occur. In contrast, binocular diplopia is also typical of strabismus. The other phenomena which can occur after onset of strabismus is visual confusion or retinal rivalry, and this occurs when images of two separate objects in the visual space fall simultaneously on corresponding retinal areas of the two misaligned eyes. The two images are perceived as coming from the same direction of the visual space. This diagram shows the situation of a patient with right eye esotropia with normal retinal correspondence. This target projects its image on the fovea of the fixating left eye, and this target projects its image on the fovea of the deviated right eye. And because of normal retinal correspondence, the two fovea have the same subjective sense of direction, and so the two targets appear to be overlapped. But foveal confusion is physiologically impossible in all age groups, whether the visual system is mature or immature. So when the two images overlap each other, this overlapped image is never seen, because two fovea cannot simultaneously perceive images of two dissimilar objects. So when an eye is misaligned, its fovea is immediately enclosed in a scotoma of 2.5 degree diameter, as represented by this black circle with a drop in visual acuity. This scotoma in the foveal area is also called central suppression, which we will be discussing next. And so instead of an overlapped image, only the image projecting on the fovea of the fixating eye of the target of fixation is perceived. And in subsequent diagrams, this black circle will represent the foveal scotoma present in all misaligned eyes to prevent central confusion. This foveal scotoma, to avoid central confusion, occurs along with both sensory adaptations of non-foveal suppression and anomalous retinal correspondence, which we will be discussing subsequently in this session. However, retinal rivalry can occur in the fovea, with image on each fovea being perceived by consciousness alternately with that of the other fovea. So at one moment we'll see this image, and in the other moment we'll see this image, and this alternation occurs rapidly. To avoid diplopia and confusion following onset of strabismus, sensory adaptations occur in the visual system in the form of suppression, anomalous retinal correspondence, and monofixation. And each of these sensory adaptations is said to occur in the visual cortex. In suppression, image from the retina of one eye is prevented from reaching consciousness during binocular viewing. Suppression is a cortical phenomena, as we have mentioned, and since it is a binocular phenomena, when one eye is occluded, suppression disappears. So when the normal non-suppressed eye is occluded, suppression in the deviated eye disappears. So in a patient, if there is strabismus and normal retinal correspondence, but the patient does not complain of any diplopia, suppression is present. To prevent the non-foveal image in the deviated eye of the target, which projects to the fovea of the fixating eye, from reaching consciousness and causing diplopia. Suppression can be classified as follows. Suppression can be absolute or relative. In absolute suppression, there is no visual sensation in the area suppressed, and in relative suppression, some visual sensation occurs from the suppressed area. Suppression can be physiologic or pathologic. Physiologic suppression occurs in normal binocular vision without strabismus to avoid physiologic diplopia for objects situated outside the Panum's area of single binocular vision. And physiologic suppression to suppress physiologic diplopia occurs both in mature and immature visual system, that is both in young children as well as in adults. Pathologic suppression occurs in strabismus and also in other forms of visual degradation such as media opacity and anisometropia. Pathologic suppression can be classified as central versus peripheral, non-alternating versus alternating, and constant versus facultative. Central suppression avoids visual confusion, which occurs in patients with strabismus and which we have discussed earlier in this session. Central suppression prevents foveal image of the deviating eye from reaching consciousness, represented by the black circle encircling the fovea in this diagram. And central suppression occurs in both immature and mature visual system, and this is important to understand. So adult onset strabismus patients will complain of diplopia but will not complain of visual confusion. They complain of diplopia because they lack peripheral suppression, which we will be discussing next, but they do not complain of visual confusion because they do have central suppression. Peripheral suppression avoids diplopia by suppressing the non-foveal image. So in peripheral suppression, the non-foveal retinal area in the deviated eye is suppressed, which receives image of the target projecting on the fovea of the fixating eye. And pathological peripheral suppression occurs only in an immature visual system, and this is also very important to understand. So in childhood onset strabismus, the patient will not complain of either diplopia or visual confusion. But as we have just discussed, in adult onset strabismus, the patient will complain of diplopia but will not complain of visual confusion. And this difference is very important to remember. And there is a difference in the extent of the suppression scotoma in esotropia and in exotropia. In esotropia, the suppression scotoma in the nasal retina of the esotropic eye is usually small and round, and limited only to the area receiving the image of the target being fixated by the fixating eye. However, in exotropia, the suppression scotoma in the temporal retina of the exotropic eye is usually larger and extends from the area receiving the image of the target being fixated by the fixating eye to a vertical line passing through the fovea in the deviating eye. In alternating suppression, suppression occurs alternately in either eye and amblyopia is less likely to develop. And this is found with alternating deviation, in which one eye is deviated at one point in time and the other eye is deviated at another point in time. Non-alternating suppression occurs only in one eye and amblyopia usually develops. This is found with non-alternating deviations, in which only one eye deviates at all points in time. Peripheral pathological suppression can be constant or facultative. In facultative suppression, suppression occurs only when the eyes are misaligned, as can occur in an intermittent exotropia. In intermittent strabismus, the eyes are deviated at one point in time, but the eyes are aligned at another point in time, and suppression occurs in the deviating eye only when the eyes are deviated. But constant suppression is always present whether the eyes are deviated or not. Management of suppression includes correction of strabismus, refractive error or media opacity, and amblyopia therapy, and these we will be discussing in the session on amblyopia. Anti-suppression exercises are not recommended because they may lead to intractable diplopia. The other type of sensory adaptation of the visual system to sensory abnormalities in strabismus is anomalous retinal correspondence, and this is also an adaptation in the visual cortex and occurs in manifest strabismus, usually of a small magnitude. In anomalous retinal correspondence, the foveal area of the fixating eye and the non-foveal area of the deviating eye, which receives the image of the target being fixated by the fixating eye, corresponds to each other. As a result, like peripheral suppression, anomalous retinal correspondence avoids diplopia. Unlike suppression, in which one eye does not see, in anomalous retinal correspondence, both eyes are seeing the target. So anomalous retinal correspondence is a superior form of binocular vision as compared to peripheral suppression. And since both eyes are seeing the target, anomalous retinal correspondence allows limited fusion and limited stereopsis, but is an inferior form of binocular vision as compared to normal retinal correspondence. Unlike suppression, which develops rapidly, anomalous retinal correspondence develops slowly and is often incomplete. The more long-standing the strabismus, the more deep-rooted the anomalous retinal correspondence becomes, which means that it becomes more difficult to restore normal retinal correspondence. Following surgical alignment of strabismic eyes, paradoxical diplopia can occur but is usually temporary. And paradoxical diplopia is a crossed diplopia in patients undergoing surgery for esotropia and uncrossed diplopia in patients undergoing surgery for exotropia. And this is just the opposite of the pattern of diplopia found in a strabismic patient with normal retinal correspondence. Anomalous retinal correspondence is rarely found nowadays because of early management of childhood strabismus. Monofixation syndrome is the third pattern of sensory adaptation to strabismus and is defined as the presence of peripheral fusion in the absence of bifoveal fusion due to a central scotoma. And this central scotoma is an absolute facultative central scotoma of 2 to 3 degrees diameter in the non-fixating fovea. Like suppression scotoma, the central scotoma of monofixation syndrome occurs only during binocular viewing. So when one of the eyes is closed, the central scotoma of monofixation syndrome disappears. Monofixation syndrome usually occurs with small angle deviations, either heterotropias or heterophorias, and this small angle is defined to be 8 prism diopters or less in the horizontal plane and 2 prism diopters or less in the vertical plane. The deviation is stable in monofixation syndrome. However, 22% of patients with monofixation syndrome have been reported to be orthophoric without any strabismus manifest or latent. 34% of patients with monofixation syndrome have been reported to have heterophoria only without a manifest strabismus, but 44% of patients with monofixation syndrome have heterotropia, often with a superimposed heterophoria. The heterotropia is commonly esotropia, but less commonly monofixation syndrome can also occur with an exotropia or an hypertropia. And only in monofixation syndrome do we find heterotropia with a superimposed heterophoria. In addition to strabismus, monofixation syndrome can also occur with anisometropia or a macular lesion. Monofixation syndrome is said to be a superior state of binocular vision as compared to anomalous retinal correspondence, which occurs with larger deviations. Because despite a central scotoma, significant stereopsis is present in monofixation syndrome up to 67 seconds of arc having been reported. And normal fusional vergence amplitudes are also found in monofixation syndrome. We will be discussing about vergence amplitudes in the session on evaluation of strabismus. And monofixation syndrome is considered as a favorable outcome of infantile strabismus surgery and is often the best outcome possible in such a scenario, and this is important to remember. Monofixation syndrome should not be confused with fixation disparity, which is present in many individuals. In fixation disparity, there is central fusion with excellent stereopsis in the presence of very minimal heterotropia, less than half a prism diopter or less than 14 minutes of arc, and this very small amount of heterotropia is not detectable by cover tests. And this small heterotropia corresponds to the area of Panum's fusional space at the fovea. Management of a patient with monofixation syndrome is the treatment of the associated amblyopia, which commonly develops in these patients. Once monofixation syndrome develops, it cannot be improved to bifoveal central fusion or normal retinal correspondence by any means. Monofixation syndrome can later decompensate to large angle heterotropia with diplopia, particularly in adulthood, but this can be corrected back to monofixation syndrome status. To recap the salient points, when a target stimulates paired retinal areas in the two eyes without causing diplopia, the paired retinal points in the two eyes are called corresponding points, which have the same directional value in the visual space. When the target stimulates the two fovea of the two eyes without causing diplopia, it is called normal retinal correspondence. And when the target stimulates the fovea in one eye and a non-foveal retinal area in the other eye without causing diplopia, it is called abnormal retinal correspondence. A horopter is a line in space. Targets located on any point of which stimulate corresponding retinal points in the two eyes and do not cause diplopia. Panum's area of single binocular vision is a limited area in visual space, including the horopter and extending anterior and posterior to it, and targets located within which are also perceived without diplopia. Anomalous is the more appropriate word. Fusion is the cortical integration of similar retinal images in the two eyes into a single three-dimensional perception. Motor fusion are vergence movements which make the retinal images of a target fall on corresponding retinal points in the two eyes. Sensory fusion is the cortical integration of the two images of a target on corresponding retinal areas of the two eyes. Stereopsis is binocular depth perception stimulated by horizontal disparity of the two images of an object being projected on the retina of the two eyes. Strabismus can lead to diplopia and potentially to visual confusion. Diplopia occurs due to retinal images from a target in visual space falling on non-corresponding retinal areas with different directional values in the two eyes. Confusion occurs when images from two separate targets in the visual space fall on corresponding retinal areas with similar directional values in the two eyes. Foveal confusion is impossible physiologically in both immature and mature visual systems. Sensory adaptations in strabismus to prevent diplopia and confusion include suppression, anomalous retinal correspondence, and monofixation syndrome. These adaptive processes can occur only when onset of strabismus occurs before reaching visual maturity, with the sole exception of central scotoma preventing visual confusion, which can occur even if onset of strabismus occurs after reaching visual maturity. Pathological suppression occurs in strabismic patients with normal retinal correspondence. The non-foveal image in the deviating eye of the target which projects on the fovea of the fixating eye is not allowed to reach consciousness, and this is peripheral suppression preventing diplopia. Also, the foveal image in the deviating eye of the target which projects on a non-foveal area of the fixating eye is not allowed to reach consciousness, and this is central suppression preventing confusion. Physiological suppression occurs in non-strabismic patients where images from targets outside the Panum's area are suppressed. Anomalous retinal correspondence is said to occur in a strabismic patient when a non-foveal area in the deviating eye corresponds to and acquires the same directional value as the fovea of the fixating eye, thus preventing diplopia. Monofixation syndrome is a binocular phenomenon in which there is peripheral or non-foveal fusion in the absence of bifoveal fusion. There is a small foveal scotoma in one eye. It can occur with both heterotropia and orthotropia and is considered to be a favorable outcome of infantile strabismus surgery. Thank you for listening.